So what is a biomarker? A biomarker is a biologic molecule that can be found in blood, fluid, or tissue that can be objectively measured and evaluated as a sign of a normal or abnormal biological process and pathogenic condition disease. Ideally, we want someone that's accurate and, this is important, enhances diagnosis or treatment decisions. Also non-invasive, inexpensive, and increased specificity over what we have now. So what do we have? Here's just a little schematic of the markers that we have today and where they can help us in our detection and decision making. We have both urine tests and blood tests for screening, our tissue-based tests for who to treat and who may benefit from additional treatment, and our circulating tumor tests and imaging for ongoing surveillance. As you can see on the bottom, genetic testing can be of value at any stage and has become increasingly important for us. We'll touch back on this later, but very important to be getting detailed and accurate histories on all of our elevated PSA and prostate cancer patients, as this can have great impacts to their treatment course as well as insight for family members. I'm going to review our current biomarkers that we have available for each of these stages in our diagnostic pathway. Let's also talk about who may benefit from these biomarkers and why, and who does not need them because it will not change our treatment choices. We'll start with screening biopsy and go all the way through to advanced disease. We have a lot of choices here, so we're going to start through with screening and early detection. So here we have Mr. Adams. Mr. Adams is 56. Initial screening PSA of 4.6, no nodules on DRE, average volume gland. He does have a family history. What do we want to do next for him? Anyone want to repeat a PSA? I rarely make any decisions based on one PSA alone. So what's the timing of this? We could recheck. There's always lab error, inflammation, infection, sexual activity, all those things that we counsel patients on why they may have an elevated PSA. Anyone want to jump into prostate MRI? Let's say we recheck the PSA and it's stable at 4.6 or thereabouts. And what if Mr. Adams says he's extremely claustrophobic and his PCP told him he has an enlarged prostate, so his PSA is probably up because of that, and he really doesn't want any further intervention? I want to sidestep here just for a moment to touch on MRI as it falls somewhat into this space and should be considered. First, biomarkers cannot and do not replace MRI in our clinical pathway, but can and should be used in conjunction and may help potentially mitigate pitfalls. But we know that not all MRI is created equal. There is a tremendous amount of variability between radiologists, variability between centers. Here's just a study from 2020 showing that the positive predictive value for Gleason grade 2 or greater has a huge range from 20 to 80%. Also, we know that MRI can miss 10 to 15% of high-risk cancers. So although MRI is needed, there is still a role for our biomarkers. We need more data on how we can integrate MRI into our diagnostic pathway with biomarkers. Should we do the biomarker first? Should we do an MRI first and then a biomarker? I think it obviously depends on the individual, the level of suspicion. Is there a discordance between MRI, PSA density, et cetera? So back to Mr. Adams. Let's say he refused MRI for now, or MRI revealed PIRADS 2 lesion. What are our options here? Remember, our goal is not to find prostate cancer. Our goal is to avoid unnecessary biopsies and find clinically significant prostate cancer. So here we have PSA. Now within PSA, we have PSA kinetics, velocity, PSA density, and percent free PSA. I think PSA density is important here, so let's review for just a moment. Recent studies have shown that the most widely used thresholds have a low detection rate, as 0.1 and 0.5 resulted in detection of 77 and 49% of clinically significant prostate cancer. Some studies discuss using 0.1 with no prior biopsy and 0.15 with a prior negative biopsy. I will often counsel patients on the benefit of an MRI is that it will give us an accurate PSA density, and that helps us understand what their PSA should be. Next, we have PHI, which is a blood test, 4K, also a blood test, and then 2 urine tests here. our Select MDX and our ExoDX. Our PHI score is an equation that takes into account pro-PSA and free PSA. Again, this is a blood test that has been around for quite some time. You'll receive a PHI score that will correlate with the probability of prostate cancer. 4K is also a blood test that got FDA approval this year. That just means that for patients with commercial insurance, they may have to pay a little copay as opposed to before they were writing off the cost. 4K uses 4 factors: the free PSA, total PSA, and human kallikrein 2, along with clinical factors, including age, DRE, and prior biopsy. Your 4K score will correlate to a probability that a Gleason grade 2 or higher or clinically significant prostate cancer will be present on biopsy. Our negative predictive value for 4K is about 96%. Next up is Select MDX. Select MDX uses a gene panel as well as clinical factors that includes age, PSA density, family history, DRE, and biopsy history. This is a urine test that does require a DRE prior. Select MDX will give you a risk for both likelihood of prostate cancer on biopsy, and will break it down further to the likelihood of detecting Gleason grade 2 or higher, or again, a clinically significant prostate cancer. The test quotes a 95% negative predictive value for Gleason grade 2 and 99% negative predictive value for Gleason grade 4 or above. ExoDX also uses a gene panel of exosomal RNA to give you an EPI score. This is a urine test, and one advantage here is it does not require a DRE because the exosomes are present in the urine without prostate manipulation. This was certainly useful during COVID because it does not require a visit. This is ideally a first catch urine that isolates urine from the prostate. Therefore, if the patient recently voided, you must tell them to wait 1 hour before voiding again to get an accurate result on the test. Here you will get a score. If less than 15.6, you're considered low risk, and if greater than 15.6, higher risk, and biopsy is recommended. The score will correlate with the risk of cancer. For example, a score of 42% will indicate a 42% risk of Gleason grade 2 or above on biopsy. This study quotes a similar 95% negative predictive value for Gleason grade 2 and above, and 97% for Gleason grade 3 and above. So I saw this patient this week and I thought I would throw it in. Interesting case. Mr. L came in. He was referred to me from inside the practice from one of our general urologists. He was 76. His PSA was 7.67, but he had some recent urinary retention after hernia repair. He did not have a PSA prior to this for several years. The referring doctor had gotten the ExoDX that was high, but an MRI as well that showed just PIRADS 1 with probable diffuse inflammation. I decided to put more stock in the MRI. Given his history of retention and now inflammation, I assumed he had a very large prostate. Maybe that explained his PSA. So we waited a few months and we rechecked the PSA, this time with a 4K, and it was again elevated. PSA was 7.4 and the 4K was 63%. I decided to repeat the MRI just in plans for the biopsy, and now surprisingly we found a PIRADS 4 lesion just a couple of months later. So obviously we took him to biopsy, and we found 5 out of 12 systematic and 4 out of 4 targeted cores with Gleason grade 5. So this was a case that the genomics was right, and the first MRI, we would have missed it.